Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/ryv. This activity is supported by an educational grant from Bayer AG. Bayer AG has had no involvement in the selection of the speakers, the development of the activity, the agenda, or the materials.
Welcome to this Congress Spotlight from European Stroke Organization Conference 2026 in Maastricht. I'm Georgios Tsivgoulis, Professor and Chairman of Neurology in the National and Kapodistrian University of Athens, and I'm going to talk you through some key updates in secondary stroke prevention in patients with non-cardioembolic stroke. There is going to be another video, educational video, regarding the benefit of factor XI inhibitors in secondary stroke prevention. So, what new information am I going to share with you regarding ESOC 2026? What's the effect of atherosclerosis status on colchicine efficacy? Are systolic blood pressure targets achievable with home blood pressure measurement plus telemonitoring versus standard care? Is dual antiplatelet therapy properly utilized in real-world practice? Let's start with colchicine for non-cardioembolic stroke. Inflammation is associated with high risk of first ever and recurrent stroke. Colchicine is a widely available and easily accessible medication that inhibits inflammatory cell mitosis, intracellular inflammasome activation, and expression of pro-inflammatory cytokines. Recent guidelines recommend low-dose colchicine for secondary prevention in cardiovascular disease. However, more insight is needed regarding its potential efficacy for secondary stroke prevention. The largest to date trial evaluating the safety of colchicine in secondary stroke prevention, as well as its efficacy, is CONVINCE trial. This trial has been published in 2024 in Lancet Neurology, and it provided evidence that colchicine was associated with numerically fewer primary outcomes, which was a composite of first fatal or non-fatal recurrent ischemic stroke, myocardial infarction, cardiac arrest, or hospitalization for unstable angina. This 16% relative risk reduction barely missed statistical significance. The p-value was 0.12. Please keep in mind that this was an event-driven trial, and the anticipated number of outcomes was not accrued because the trial was terminated earlier due to budget constraints. However, in a very important pre-specified analysis in the on-treatment population, colchicine was associated with a 20% reduction in the primary endpoint, and this association was significant. So, in ESOC 2026, a very timely secondary analysis was presented by CONVINCE investigators in patients with large artery atherosclerotic stroke. They reported a 70% relative risk reduction in the intention to treat population. This association was not significant, but again, in the on-treatment analysis, there was significant reduction of atherosclerotic stroke, 24%. Interestingly, in this specific analysis, patients with no atherosclerotic stroke had no benefit with colchicine. The p-value for interaction was 0.37. However, this secondary pre-specified analysis provides valuable insights that colchicine may be actually more efficient in atherosclerotic stroke subtype. I wish to remind everybody that stroke is a heterogeneous group of cerebrovascular disorders, and there are multiple ischemic stroke subtypes. Atherosclerotic stroke subtype is the one carrying the highest risk of stroke recurrence, and in this specific subtype, we see that there may be some signal of efficacy with colchicine, and we're looking forward for the currently designed CONVINCE trial. Moving now to another topic, which is home blood pressure measurements with telemonitoring. This is the phase 2 EPIC pilot trial. This trial compared home blood pressure measurements coupled with telemonitoring versus usual care that consisted office blood pressure measurements, ambulatory blood pressure measurements, and home blood pressure measurements. So the primary outcome was the difference in mean office systolic blood pressure at 12 months. A total of 27 patients with non-cardioembolic ischemic stroke or high-risk TIA were recruited. The target was to achieve systolic blood pressure levels less than 130 millimeters of mercury during the follow-up period. Patients who were randomized to the intervention group had their home blood pressure monitoring diary reviewed by the study team, and if systolic blood pressure levels were out of the allocated target range, a prescription to titrate antihypertensive medication was sent to the patients at a monthly basis. These results were very promising. In a small sample of 27 patients, you can see that already at 3 months there is a 10 millimeter of mercury, statistically significant difference with home blood pressure and telemonitoring. Interestingly, at 3 months in the intervention group, the target systolic blood pressure level was achieved in 62% of the study sample compared to 9% in the usual care group, and of course this difference was significant. Let's now move to another important study that was presented in ESOC 2026. This study evaluated the utilization of dual antiplatelet therapy in real-world settings. This was a retrospective single-center study that evaluated the use of dual antiplatelet therapy in point-eligible patients. So this study evaluated the patients with history of stroke in the single center over a period between 2014 and 2023. And I wish to remind to our audience that in 2018, the point results were published. In 2014, only 15% of point-eligible patients were treated with DAPTs. What is surprising was the fact that in 2023, this number increased to 43% only, and a substantial number of patients, 74.3% of point-eligible patients, did not receive dual antiplatelet therapy between 2018 and 2023. So during a time period of 6 years following the publication of point results. It was very interesting the fact that prior aspirin use was associated with 99% reduction of dual antiplatelet use, and of course this association was highly significant. Before I wrap up, please answer this challenge question. So, what we have learned regarding secondary prevention in ESOC 2026. First of all, colchicine is an inexpensive drug that can help reduce the risk of MACE and recurrent stroke in patients with history of atherosclerotic stroke. This is a very important pre-specified analysis from convinced investigators, highlighting the fact that colchicine may be more effective in this specific stroke subtype with large artery atherosclerosis. The second thing that we learned is related to home blood pressure measurement and telemonitoring. This may be a very powerful intervention tool for achieving our targets of low systolic blood pressure in secondary stroke prevention. These were very promising phase 2 results that await a large phase 3 trial to be further verified in a larger sample of patients. Finally, we must make sure to use dual antiplatelet therapy in eligible patients with history of minor stroke or high-risk TIA including those already on aspirin, and these patients should be swiftly switched from aspirin to dual antiplatelet therapy with either aspirin and clopidogrel or aspirin and ticagrelor. And now, please answer the second challenge question. Thank you for watching. Welcome to this Congress Spotlight from European Stroke Organization Conference 2026 in Maastricht. I'm Georgios Tsivgoulis, Professor and Chairman of Neurology in the National and Kapodistrian University of Athens, and I'm going to give you a quick overview of Factor XI inhibition in stroke, including the latest updates from the Congress. Factor XI inhibitors have the potential to uncouple pathologic thrombosis from hemostasis because they inhibit only the intrinsic coagulation pathway. Consequently, they can prevent stroke with minimal bleeding risk. This hypothesis has been evaluated in two phase 2 trials. The first one is Pacific-Stroke, and the second one is Axiomatic-Stroke, and it has been further evaluated in 3 large phase 3 clinical trials. The first one is OCEANIC-Stroke for non-cardioembolic ischemic stroke and high-risk TIA. The second one is LIBREXIA-Stroke for the same group of patients, and the third one is LILAC-TIMI-76. OCEANIC-Stroke is evaluating asundexian. LIBREXIA-Stroke is evaluating milvexian, and LILAC-TIMI-76 is evaluating a monoclonal antibody abelacimab. Please keep in mind that both asundexian and milvexian have been evaluated in the population of atrial fibrillation in the OCEANIC-AF and LIBREXIA-AF clinical trials, respectively. OCEANIC-Stroke has recently been published in the New England Journal of Medicine. It was a positive trial that showed that asundexian at a daily dose of 50 milligram coupled with antiplatelet therapy was associated with a 26 relative risk reduction in the first incidence of ischemic stroke compared to placebo and standard antiplatelet therapy. This 26 relative risk reduction corresponded to an absolute risk reduction of 1.6 events per 100 patient years, and this translates into a number needed to treat of 53 to prevent 1 ischemic stroke per year. There were no safety concerns in terms of major bleeding events defined according to the International Society on Thrombosis and Hemostasis criteria. During ESOC 2026, there were multiple publications and presentations from the OCEANIC-Stroke investigators evaluating the beneficial effect of asundexian in the severity of recurrent stroke, the net benefit and time course of asundexian treatment effect, and evaluating the risk of intracranial hemorrhage in patients treated with asundexian. Finally, OCEANIC-Stroke investigators reported on the predictors of recurrent stroke in this trial. The first presentation showed that asundexian effectively reduced the risk of disabling and fatal stroke by 31%. It also reduced the risk of large vessel occlusion stroke that required thrombectomy by 39%, and it also reduced the risk of moderate or severe stroke defined by NIH stroke scale score of 8 points or greater. So these were all significant risk reductions. The OCEANIC-Stroke investigators reported also to different factors that were independently associated with the risk of recurrent stroke in the trial. They were older age, other age, not Black or Asian, history of diabetes, history of previous stroke or TIA, index large artery atherosclerotic stroke, and history of atherosclerosis. And these associations were significant after adjustment for potential confounders in multivariate models. The beneficial effect of asundexian with regard to the primary endpoint, which was incidence of ischemic stroke, was consistent across the whole time period of the follow-up. More specifically, for the time period between day 1 and day 90, there was a 16% risk reduction that barely missed statistical significance. For the time period between 91 and 180 days, the risk reduction was 23%, which was also not significant. From day 181 to 365, there was also a very significant risk reduction of 49%, and during the remaining time of the follow-up, there was a consistent risk reduction of 31%. So you can see that during the whole time period, there was a consistent beneficial effect of asundexian. OCEANIC-Stroke investigators evaluated the net benefit of asundexian in terms of combining both safety and efficacy endpoints. They showed that asundexian was associated with a significant 18% risk reduction in ischemic stroke or ISTH major bleeding. It was also associated with cardiovascular death, all stroke, MI, or ISTH major bleeding by 15%, and it was also associated with a reduction in all-cause mortality, disabling stroke, fatal bleeding, symptomatic intracranial hemorrhage by 19%. There were no safety concerns with asundexian in terms of all the safety endpoints. There was no increase in intracranial hemorrhage, no increase in hemorrhagic stroke, no increase in subdural hemorrhage, no increase in disabling and/or fatal intracranial hemorrhage, and no increase in disabling and/or fatal hemorrhagic stroke. Intracranial hemorrhage and hemorrhagic stroke were rare in this trial. However, it is very interesting that the number of these hemorrhagic events was actually lower in the asundexian group compared to the placebo group. There is another phase 3 trial, LIBREXIA-Stroke, that is currently evaluating the safety and efficacy of milvexian at a dose of 25 milligrams twice daily compared to placebo in the same population of stroke patients. However, there are some differences in inclusion criteria between LIBREXIA-Stroke and OCEANIC-Stroke. LIBREXIA-Stroke is a more restrictive trial that includes patients with minor stroke, defined with an NIH stroke scale score of 0 to 8, whereas OCEANIC-Stroke included patients with minor or moderate severity stroke with an NIH stroke scale scores ranging between 0 and 15. Also, the threshold for inclusion in LIBREXIA-Stroke in terms of age was 40 years of old or greater. In contrast, in OCEANIC-Stroke, this threshold was 18 years old or greater. Before I wrap up, please answer this challenge question. So, in conclusion, the investigators of OCEANIC-Stroke trial reported during ESOC 2026 the beneficial effect of asundexian in reducing the incidence of severe stroke, fatal stroke, large vessel occlusion stroke requiring thrombectomy, stroke of moderate severity of NIH stroke scale score of 8 points or greater. They provided strong evidence that the beneficial effect of asundexian persisted during the whole follow-up period at different time points. They also provided strong evidence that asundexian was effective in terms of the net clinical benefit that combined both ischemic and hemorrhagic events. Finally, there were no concerns regarding different safety endpoints, including symptomatic intracranial hemorrhage, subdural hematoma, hemorrhagic stroke, fatal hemorrhagic stroke. there were no concerns with asundexian in terms of safety. And now, please answer this second challenge question. Thank you for watching.
This has been an activity published by PeerVoice.